The doctor told me that, look, you have hepatitis B, so you cannot go overseas. No one at all from my village had that opportunity to go overseas for study. And for sure, my parents would not be able to afford any of that. So having a scholarship to study overseas is actually a really big deal for someone from a village in the north of Vietnam. And I was lucky enough to secure a scholarship to study in Europe. And as a part of the paperwork, I have to go through a health check. And hepatitis B test is among the health check. So when I came to get the result, the doctor told me that, look, you have hepatitis B, so you cannot go overseas. And then I had to reject the scholarship just because he told me so. I don't know why, by that time, I didn't challenge him or explore more, whether what he said was correct. But look, as a first year university student and you had no experience in life, and then you tend to trust everyone that deem to be more superior than you, like the doctor in the hospital.
In the time it takes to watch this 30-second video, someone will lose their life to hepatitis. It could be your parent, your partner, your child. It could be you. But it doesn't have to be this way. There is a cure for hepatitis C, a vaccine and effective treatment for hepatitis B. We have the power to eliminate hepatitis and save 1.1 million lives each year. It's time to act. Hepatitis can't wait.
Hoy es un día muy esperado para todos los integrantes de la Asociación Buena Vida, porque celebramos la cura de varios pacientes de hepatitis C. Nosotros en nuestro grupo decimos que vivir con el virus de hepatitis C es sentir que uno tiene una bomba de tiempo dentro de uno y que no sabe cuándo va a explotar. La cura significa desactivar esa bomba. Por eso estamos todos juntos hoy para festejarlo, entregar las remeras con la inscripción de hepatitis C curado, y ese es el momento cúlmine de nuestra labor como voluntarios de la Asociación Buena Vida.
Soy Raúl y estoy curado.
Soy Majo, estoy curada.
Soy González Julio y estoy curado.
Hola, soy Susana y estoy curada.
Soy José Luis y estoy curado.
Soy Graciela y estoy curada.
Soy Adrián y estoy curado.
Soy Andrés y estoy curado. Hola, soy Miguel y estoy curado.
Hola, soy Gabriel y estoy curado.
Soy Carlos y estoy curado.
Soy Nelly y estoy curada.
Soy Claudio, estoy curado. Soy Rubén y estoy curado.
Good morning, good afternoon and good evening to everyone who's joining this session. My name's Ahmed Al-Shakawi. I'm a hepatologist in Birmingham in the UK and a senior honorary lecturer at the University of Birmingham. It gives me great pleasure and it's really my honor to chair this session today. We have 3 lightning talks on prevention and vaccination for you today. The first 2 will be videos and the last one will be a live presentation. I'd urge you please to think of questions as you go along and type them in the Q&A function on the platform so that we can get to them in good time and hopefully answer as many questions as possible. So without further ado, we're going to start off with the first talk from Partha Mukherjee, who is a public health activist in West Bengal in India, and who's going to give us a talk about the impact of vaccination in rural communities. So can we play Partha's video, please?
It's a pleasure to meet you and greet you on behalf of Liver Foundation West Bengal from the city of joy in this World Hepatitis Summit. Today my topic is customized active engagement can increase hepatitis B vaccine adherence in remote tribal communities. We know that we have an elimination target, eliminate hepatitis, viral hepatitis by 2013. And we have strategic direction to achieve these targets, and we have very important components in this elimination program to reduce the new infection by 90%, to reduce the death by 65% by 2030. So we are engaged in hepatitis prevention and elimination activity. We, Liver Foundation, are very much active in hepatitis prevention activity for last 15, 16 years. And we have taken different initiatives with this regard. And we have undertaken one program which is known as Reaching the Unreachable in 2018. Just to support the very important concept, find the missing millions. So it was happened in Hilltop village of backward district of West Bengal. And we planned to organize, we launched this No Hep 23 program in 2018 when National Viral Hepatitis Control Program launched in the country. And it was launched on 28th of July on 2018. And it was targeted to make 23 villages hepatitis free in 23 districts of West Bengal. It was a very small target to make one village hepatitis free or wanted to eliminate hepatitis in that particular village. But we thought that if we can achieve these small targets, then it will give us some impetus and confidence to achieve the larger target which we have, elimination hepatitis by 2030. So primary objective of this program was to make available the accessibility of tests and treatment of hepatitis B and C in these unreached tribal areas. The plan of the first phase was primarily hepatitis awareness, and it was organized by rural healthcare providers of that locality. They organized awareness program. Approximately 530 people live in that village. About 80% of the villagers were screened for HBV and HCV in the first phase. About 53 of the screened people complete full dose vaccination. 2 villagers were identified as hepatitis B positive. One was identified as asymptomatic carrier, and one as diagnosed as decompensated cirrhosis in further diagnosis and are getting regular clinical treatment, management and treatment at Indian Institute of Liver and Digestive Sciences, which is a unit of Liver Foundation West Bengal. We found that only half of the screened population fully immunized in the first phase. And we thought that lack of hepatitis awareness, stigma associated with vaccine, lack of understanding about immunization benefits, that vaccine hesitancy, trust deficit, all these are very important cause. And high rate of alcohol addiction was a cause for unavailability of the subject in that particular areas. And these were the limitation of the first phase intervention. Then we tried to take some measures to minimize the project limitations. And we have started regular community meet, focus group meeting with the community leaders and door-to-door campaign. Setting up permanent billboards at various locations was also very impacting because it was a sort of a regular reminder to them that we have a responsibility to take vaccine and to make themselves that hepatitis free. Also, we formed a different no hep team, that community, engagement of local youths, no hep leaders. Amongst the students, we found no hep advocates, and also we formed no hep mothers, those who have completed the vaccination. Also, we converted these patients, those who are diagnosed with hepatitis B, as no hep ambassadors.
Los diagnósticos de hepatitis B. A ver,
Results after this type of preventive measures, we found that Sitarampur showed 31.5% more adherence to the vaccination program with active advocacy. We also found that seasonally migrant population of Sitarampur completed their vaccination course by themselves. We have initiated this activity also in other villages, in other districts, which is known as Katabuni, which was also tribal dense village. And in this second side of intervention, we found that active advocacy led to 81% of the screened population completing the hepatitis B vaccination in the first attempt. And also we found that 276 adults from both the sides were fully vaccinated after active advocacy programs was initiated by the different community members. So what was the lessons learned? Adaptation of new strategies to promote better understanding of vaccine importance is necessary for attaining SDG by 2030. For a long-run awareness come intervention program, sustained awareness campaign is essential. The campaign needs to be owned by the local community. Doctrine-guided awareness campaign will not yield in higher compliances. The involvement of women and adolescents girls is key to approach and mobilize the entire family unit. Inclusion of local communities in the marginalized and tribal areas is critical for hepatitis prevention initiative.
Thank you very much, Partha, for that. That's a great presentation. We haven't got any questions immediately, so what I'm going to suggest is we go through the next two presentations and we come back and do a question and answer session at the end. So can we have the next video? The next video is by Michaela Jackson, who is presenting on behalf of the Hepatitis B Foundation from the US. Michaela is their prevention policy manager, and her talk is going to be about increasing adult vaccination in the United States. Can we have Michaela's video, please?
Hi, everyone. My name is Michaela Jackson, and I am the Prevention Policy Manager for the Hepatitis B Foundation. I'm very excited to speak with you today about the U.S. efforts to increase adult hepatitis B vaccination and how it will help advance health equity. So as a little bit of background, hepatitis B remains a significant issue in the U.S., with an estimated 2.4 million Americans living with chronic hepatitis B. In recent years, the country has seen outbreaks of acute hepatitis B, especially amongst states impacted by the opioid epidemic, in addition to rises in the national rates of hepatitis B. We are seeing significant increases in Hep B amongst ages 30 through 49, which is a group that missed the universal infant vaccination recommendation. Preventative vaccines have been widely available for over 30 years, but adult hepatitis B vaccination rates still remain low in the United States. In 2020, the U.S. Centers for Disease Control and Prevention's Advisory Committee on Immunization Practices, or ACIP, began to review evidence to determine if all adults should be vaccinated for hepatitis B. The formal review process allowed for plenty of opportunities for the public to provide input, so we set out to make it as easy as possible for community members to add their thoughts. The ACIP vote was really a one-shot opportunity, so we knew that we had to make it count. So listed on the slide here are two objectives that we sought, which are one, to promote universal adult hepatitis B vaccination, and two, to highlight the need for increased adult hepatitis B vaccination. While the ACIP's hepatitis work group provided the committee with essential data such as cost-effectiveness information, limitations on risk-based recommendations, and how universal vaccination can aid in health equity, the job of the public health community was to provide real-world information about how the recommendations played out in practice. Using a multi-pronged approach that included the methods listed on the slide, the Hepatitis B Foundation was able to mobilize advocates, key stakeholders, and legislators to speak out about the importance of this vote. We also wanted to be as prepared as possible for the potential universal recommendation, so we conducted a survey with several of our partners that showcased what resources and support state and local health departments needed to be able to carry out the recommendation. So we were not just thinking about the vote and all that was happening right then and there, but also what could potentially be coming after the vote to make sure that we had the resources that were needed. After about a year and a half of advocacy, the ACIP voted to approve universal hepatitis B vaccination for all adults up to age 59, and the recommendation was officially adopted into policy in April 2022. Adults 16 older with risk factors are also recommended to receive the vaccine underneath this new policy. I wanted to take a moment to highlight that the passing of this recommendation was truly thanks to the hard work of the community. This was by no means an easy vote. There were many questions about why this recommendation was needed and if it made sense to include all age groups. The community perspective was integral to showing that voting members that policies that look great on paper might not always pan out in practice. One of the most important things that this recommendation does is to eliminate financial barriers to vaccination, such as cost sharing when you have insurance or paying directly out of pocket. Another thing is that it helps to decrease stigma amongst communities that are at higher risk. We are no longer singling people out for certain factors. We can just widely recommend the vaccine for everyone. It makes it a lot easier for providers to recommend the vaccine to adults, and it also helps to increase access to the vaccine as well. All of these barriers that have been eliminated are helping us move towards creating a more equitable space within viral hepatitis community. Now that we have this incredible recommendation, we need to work on making sure that it will be implemented successfully. The Hepatitis B Foundation has taken several steps to ensure successful implementation by including the creation of a hepatitis B vaccine and screening advisory council to develop implementation strategies for different public health settings. We will continue to raise awareness among patients and have expanded education efforts to make sure that all providers are aware of the new recommendation as well, including primary care. Finally, this recommendation came with no increased funding. Our survey showed that most states receive less than $1 million to cover all vaccines for adults, so now we must work to secure increased funding for immunization programs in order to uptake the new recommendation. This will certainly take more advocacy and the collaboration with the larger public health community, and we look forward to working with them. And so, the final slide, I just wanted to offer everybody an opportunity to reach out and ask us any questions. Thank you.
Thank you very much, Michaela, for your presentation. And we'll move on to the last presentation of the session, and then we'll have a question and answer session after that. So it gives me pleasure to welcome Nick Walsh from Monash University in Australia, who's going to present to us a systematic review of the effectiveness, immunogenicity, and impact of pediatric hepatitis A vaccines. And in fact, this is the first time I've heard about hepatitis A at this meeting. Nick, over to you.
Yeah, thanks very much. I assume my sound is okay. I'm presenting loud. Great. I mean, live. So this is a systematic review of hepatitis A vaccines in pediatric populations. It's a lot of work. We've got 5 minutes now, so I'm just going to skirt over the top of the main issues. Briefly, hepatitis A is overlooked. It's a major issue, 160 million acute infections worldwide, 40,000 deaths each year, lots of DALYs. Obviously, there's a geographic distribution. The last time WHO had a position paper was in 2012, and there was limited evidence on single-dose immunization. That was an option for some national programs at the time, but again, limited evidence. The recommendation was for 2-dose schedules. However, since 2012, there's been an increase in single-dose national programs. Just before I get into the results, I would just like to acknowledge the SAGE Hepatitis Working Group members listed here from all around the world, and the Secretariat listed here from the various regional WHO offices, and my colleague Joanna Torres, who helped substantially. In order to plug the gap on the data, we undertook a systematic review and meta-analysis comparing single versus multi-dose, as in 2 or 3 dose hepatitis A vaccine schedules, on the effectiveness, immunogenicity, impact of live attenuated or inactivated vaccines, looking at long-term protection. We looked at safety and did some cost effectiveness and impact analysis as well. I won't go through the details. Here are the PICOs. The two questions were, are hepatitis A vaccines, one, safe, and two, effective to prevent clinical disease being the operative words, transmission and confer seroprotection. Number two, do hepatitis vaccines confer long-term protection against disease and seroprotection? We searched briefly all of the various libraries from 2012 to the beginning of 2021. These are the results. Hepatitis A vaccines clearly highly effective in preventing clinical disease. There was no difference in short or long-term greater than 7 years comparing hepatitis A single or two-dose schedules in terms of clinical disease and seroprotection. The only issue was the geometric mean concentration was lower for single-dose schedules. Hep A vaccines are safe. Adverse events were mild and infrequent. Both 1 and 2 dose schedules had a substantial population level impact, and they're both cost effective, but 1 dose schedules are cost saving. So in just diving a little bit deeper into the results, not too much deeper, in terms of the effectiveness, we found that it didn't matter whether you were using live or inactivated vaccines, single versus multi-dose. There was no difference in the effectiveness, and that effectiveness remained up to or over 7 years. There was, as I said, a difference in the geometric mean concentration, as in the antibody titer. In terms of safety, we didn't find any major safety signals. Even the adverse events was consistently lower across all of the studies. Some of the limitations were the small sample size and that most of the live data was coming from 1 or 2 countries. Just to show the picture of impact, looking at before, which is dark blue, and after, light blue. This is notifications or reported hepatitis A cases in a variety of different settings around the world, including Argentina, Brazil, Russia, Italy, China, Israel, and the United States. You can see just visually a major change in hepatitis A reported incidence before and after the introduction of a single dose on the left and 2 dose on the right inactivated vaccine programs. In terms of the percentage decrease, what I'm showing here is in the group of graphs on the top right, the single inactivated vaccine national program or regional program showing a up 80+% reduction in reported cases, single dose live attenuated in the middle on the right, showing between 50 and 80% reduction in new cases reported, and down the bottom in dark blue, large decreases when 2 dose programs are initiated. The bottom line is there really isn't much difference when you compare 1 or 2 dose schedules. Remember that live attenuated are always 1 dose schedules. In terms of looking at the modeling, we looked at longevity extrapolation studies. There were 4 studies, population-based epidemiological impact models and economic impact models. In terms of the extrapolated studies, there were 2 major studies. An Argentinian study modeled based on empiric data up to 30 years. There was no difference in the persistence of seropositivity, and there was very little impact on the naturally acquired immunity in the environment. A Chinese study of a 2-dose modeled to 60 years, there was and was able to demonstrate antibodies in this modeling study at 60 years. In terms of vaccine...
Nick, can I ask you to wrap up the last minute, if that's okay? Apologies.
Sorry?
Can I ask you just last minute of presentation, just conscious of time?
Great, thanks very much. In terms of the population impact, there was a major population impact for both 1 and 2 dose schedules. Herd immunity was critical and is important in terms of economic modeling. In terms of cost effectiveness, there was no difference in terms of the cost effectiveness, but we did find the single dose schedules were cost saving, particularly in high endemicity countries. This is my final slide. So the evidence supported 1 or 2 doses for national pediatric programs. We graded the evidence. A background paper was prepared and recommendations delivered at the SAGE immunisation meeting in April this year, WHO is now drafting a new position paper to be published in late 2022. Thanks very much.
Thank you, and apologies about having to cut you off at the end. Can we have all the presenters on screen if possible, please? So I'm going to start off with a question to you, Partha. It was fascinating to me that actually you found that the greater advocacy were if you got adolescent girls or women. Was your uptake of vaccines split by gender as well once you got the advocacy, or once you got the advocates and the champions on board, were you able to vaccinate equal numbers of men and women, or was it still much more skewed towards women?
Yeah, no, it's not that difference in vaccine, that uptake by women and men, but most importantly that we found that women are most, that they can disseminate the information with regard to the community empowerment, community-led initiatives, and community, that engagement. They have taken a much important power. And as an example, I would like to tell that addiction rate was very high amongst that indigenous population, tribal dense population. And because of males are mostly alcoholic, then women's, but that's why the vaccination rate was much less initially in the first phase of amongst the men. But when this community initiative and advocacy was done, I think it was more or less similar.
Okay, that's interesting. So a question from the platform to you, Michaela. In the US, after universal adult vaccination recommendation, what's the cost to the consumer for the complete series? So what does the actual individual who's been vaccinated have to pay?
Yes, that's a great question. So for everybody, all adults up to age 59, it should be completely free. They will not have to pay any money out of pocket. For those 16 older who are not included in the recommendation and they don't have any noticeable risk factors, or they don't disclose their risk factors, they might have to pay out of pocket, which depending on the vaccine, it can be up to $240 in total for a series. So that's something we are concerned about, but yeah, for most people, it will be free.
Okay, thank you for that. Question to you, Nick. I mean, you skimmed over it, but there hasn't been a specific question of what's the information on the waning of Hep A immunity post Hep A vaccination? Number one. Number two, I must say, I hadn't thought about 39,000 deaths annually worldwide, easily preventable. And so what percentage coverage is there for Hep A vaccination up and down, globally?
Yeah, to answer the second question first, there's 39 million doses of vaccine administered a year. That doesn't count China. China's obviously administering a lot of vaccine. In terms of the waning immunity, one has to understand that you do get seroprotection out to 30 years, but you have T-cell mediated anamnestic memory such that you can induce an immune response even in individuals without antibodies 17 years down the track. So the long-term immunity is strong, and the immune memory is strong as well. I just wanted to mention that one quick thing is that there is another session on hepatitis A vaccine, the new WHO position paper. It's chaired by Rakesh Akarel, and Fumi will be there as well, and that's in the program.
Lovely, thank you for that. That's a useful signpost to people. Okay, going back to you, Michaela. Obviously, the opioid epidemic is driving a lot of the Hep B increase in the 30 to 49-year-old populations that you mentioned. Do you have a sense of what percentage coverage of first dose vaccination you've got? But also, actually, everyone reports first doses, but certainly here in the UK, no one reports second and third doses when most vaccines are 3-dose schedules. So do you have any information on that?
That's a great question. And unfortunately, we don't have clear data. The US has not a great surveillance system for hepatitis B. Tracking vaccine doses in adults is also very terrible. So I would have to say that we know that they're not getting it. It's very clear. About 36% of new infections for hepatitis B are just from this population by itself. And so, yeah, there's not a lot of new information or new data on that, but we need to do better.
Okay, thank you for that. Partha, back to you. I mean, there's comments in congratulating you on your work in the question and answer section. There's something about the empathy program campaign in India that's done something very similar. Do you think your work and your lessons are applicable in all rural communities? Or is there specific, I suppose, is there specific lessons that you think may not be applicable elsewhere?
I think it is applicable for all communities. We believe on, that bottom-up action, not top-down. And when you will do something with the community, I think, for an example, I'd like to take just a minute, a few seconds, that, we learned from the COVID that in India, initial vaccine hesitancy, this vaccine trust was very common. That there was no trust of vaccine, hepatitis B related vaccine earlier. We found very difficulties, very challenging with regard to the trust of hepatitis B vaccine. But subsequently, when COVID came, it was a huge noise, and that multi-level campaigns were there to advocate why COVID vaccine should be injected. And subsequently, we had a very good success during the first dose of COVID vaccine. So I think we need to create more noise, more community empowerment, more community-led initiative across the globe, so that we can reach the target.
Okay, well, that's a great message, and that's a great message to end on. We're officially out of time, so all that remains for me to do is thank Partha, thank Michaela, thank Nick. Thank you very much. Apologies, we haven't had time to answer more questions, and thank the audience for listening. So have a great rest of the summit. Bye bye for now.